Recording in progress.
Well, welcome everybody to another episode of the Sydney Neonatal Lectures. It is my great honor to introduce Professor Satyan Lakshminrusimha. He's a neonatologist from the University of California, works at UC Davis Children's Hospital. His interests are neonatal hemodynamics, transition, oxygen, resus, but as I know him, above all, physiology, and he can explain it excellently. And today he will talk to us about the interesting combination of HIE, cooling, and PPHN, appropriately called Beyond the Chill. So over to you, Satyan.
Thank you, Kurt, for the kind introduction and for having me here. I hope all of you can see my slide.
Yeah, it's there.
Okay, perfect. Okay, so as Kurt mentioned, we'll talk about PPHN during therapeutic hypothermia. And as I was telling him earlier, I'm not an expert in echocardiography, so most of my talk will be focused on gas exchange, hemodynamics, and physiology, and some therapeutic options. Okay, I don't have any relevant financial disclosures. As many of you know, most of the drugs that we use in this age group are not approved. And some of the data I present is based on animal studies and has a low quality of evidence. And most of the figures that I'm going to show you in this particular talk are from these clinics in perinatology, which I was lucky to edit with Steve Abman, and has lots of chapters dedicated to PPHN. And we were fortunate to have Regan Geisinger present a paper on asphyxia, hypothermia, and pulmonary hypertension in this book, and it's a lovely read for those of you who haven't read it earlier. Okay, so the essence of my talk is that if you have significant lung disease, perinatal asphyxia resulting in needing therapeutic hypothermia, and a baby who has hypoxic ischemic encephalopathy and PPHN, the combination of these three entities results in a higher need for inhaled nitric oxide and ECMO. And the question is, how can we avoid this, and how can we treat these babies better so that the risk of requiring nitric oxide and ECMO is reduced? That's the essence of the whole talk. So to give you a rough idea of why we are concerned so much about this, we did a recent study of all the babies born in California state, which is we have around 400,000 babies per year. And over a 8-year period, we had 2.8 million babies born here. And of these, around 15% of them required an NICU admission, and 6.5% of them required mechanical ventilation and or surfactant. What was interesting is that among these babies, 4,300 babies required inhaled nitric oxide and 682 required ECMO, and 258 died after ECMO. So we went back and looked at these 682 babies that required ECMO over a period of 8 years in California, and we were expecting to see that the number one indication for putting a baby on respiratory ECMO was congenital diaphragmatic hernia, which is what we had expected. To our surprise, what we found was that even more common than CDH was the combination of various factors, such as meconium aspiration syndrome, hypoxic ischemic encephalopathy, sepsis, etc. On the whole, these babies getting therapeutic hypothermia for HIE this was a more common indication for neonatal respiratory ECMO, even more common than CDH in our population in this state. So we went back and analyzed data over a period of these 8 years, and we found that the number one indication was, lo and behold, whole body hypothermia. And this was associated with ECMO in California. The second association was diaphragmatic hernia, third was sepsis, and the fourth was meconium aspiration syndrome without hypoxic ischemic encephalopathy. So what I want to point out is that when you see a baby with meconium aspiration syndrome in the NICU, you have two possibilities. One is the good old meconium aspiration syndrome with respiratory symptoms without hypoxic ischemic encephalopathy. And this particular group had approximately 2,800 babies in our cohort, of which 27% of them required inhaled nitric oxide, and 3.9% of them required ECMO. In other words, among babies that required inhaled nitric oxide, 14.4% of them failed, needing ECMO cannulation, and the overall mortality was 2.2%. If you compare that with babies with HIE and meconium and hypothermia, this perilous combination of these three entities, the number of babies in this group was 290. And what was striking was that almost half of them required inhaled nitric oxide. And of the babies that got inhaled nitric oxide, 1 out of 5 babies needed ECMO, and the mortality was 12.4%, almost 5 times as high as babies with meconium aspiration without HIE. Some of this mortality was secondary to withdrawal of support due to HIE. So this is difficult to attribute this completely to PPHN. But I just want to point out the fact that the combination of these three entities can have poor prognosis compared to meconium aspiration syndrome alone. So let's look at the effect of temperature. What does temperature do to these babies? Let's look at the chill aspect of this talk. So it's pretty evident to us at this point that perinatal asphyxia can result in meconium-stained amniotic fluid, and around 14% of these infants result in meconium aspiration syndrome with respiratory symptoms. Around 36% of babies with meconium aspiration syndrome land up having PPHN, and similarly, approximately a quarter of babies with hypoxic ischemic encephalopathy, moderate to severe, tend to have PPHN. In addition, undergoing therapeutic hypothermia does result in some degree of pulmonary vasoconstriction, and around a quarter of these babies have PPHN as well. So all these things play a role in establishing pulmonary hypertension in these babies, and this might require therapy with inhaled nitric oxide or ECMO. So again, the fact that these babies get cooled and the reduced temperature can result in pulmonary vasoconstriction. It's important to note that not only is cooling a dangerous period, even rewarming can cause systemic vasodilation and drop systemic vascular resistance and exacerbate PPHN in these babies. So cooling, especially deep cooling that can occur during passive cooling or during transport, can exacerbate pulmonary hypertension and worsen oxygenation in these babies. So when you look at the data from the NICHD NRN Neonatal Research Network trials conducted by Dr. Sita Shankaran, what she has shown is that even babies managed in standard arm in the past with normal temperature tend to have a fairly high incidence of systemic hypotension, PPHN, and require inotropic support, inhaled nitric oxide, and ECMO. On the other hand, if you cool babies to moderate degree of hypothermia with 33.5 degrees centigrade core temperature, the incidence of these entities is roughly similar to what happens with standard temperature. In other words, a quarter of these babies have PPHN, and approximately half of them require inotropic support. In contrast, if babies get cooled even deeper to 32 degrees centigrade, which was done in one trial by Dr. Shankaran, the incidence of need for inhaled NO was higher, need for ECMO was even higher, and this trial had to be stopped a little early for that reason. So in other words, 1 out of 4 infants with HIE undergoing whole body hypothermia has PPHN, and a third require inotropic support. And if the babies undergo deeper cooling to 32 degrees centigrade, then almost 1 out of 3 babies has PPHN, and half of them need inotropic support. So the incidence of pulmonary hypertension requiring treatment and need for inotropic support is pretty high in this population. So 2 things to look into. One, what can cause deep cooling inadvertently? There are 2 possibilities. One is passive cooling. The second is also depends on which type of monitor that you use to monitor babies during hypothermia. So while undergoing whole body cooling, some centers use a rectal probe, rectal temperature monitor, and some centers use an esophageal temperature monitor. I find it interesting that we do place an esophageal probe, but then if these babies are intubated, we connect this endotracheal tube to a ventilator and a humidifier and heat this gas to 37 degrees centigrade and pass that gas into the lungs. And although the baby is being cooled, the lungs are kept in a warm state due to the ventilator circuit. But interestingly, studies have shown that this maintenance of normal temperature in the ventilator circuit doesn't really alter the esophageal temperature as much as I thought it would do. But either way, this was a trial where they looked at the HEAL study patients, the study where they combined therapeutic hypothermia with erythropoietin and compared babies retrospectively as to those that had esophageal temperature monitoring and rectal temperature monitoring. What was interesting was that there was no change in death or neurodevelopmental outcome. Seizures were also similar between the two groups, but the risk of overcooling or reaching a temperature less than 33 degrees centigrade was much more common with esophageal temperature monitoring than with rectal temperature monitoring. And similarly, the incidence of hypotension and any cardiovascular complication was also much higher when they used esophageal temperature monitoring. So based on these findings, it's probably prudent to use a rectal temperature monitor while monitoring babies during therapeutic hypothermia to avoid the risk of overcooling in these babies. Although the randomized trials have not shown any difference in the incidence of PPHN between cooled and standard treatment arms, when you look at real life, there are studies to show that in babies that have undergone hypothermia, despite having similarly acidotic gases, the incidence of PPHN can be significantly higher. For example, 23% in this cohort in the hypothermia group compared to 11% in the control group. And this is what we see in real life as well. In my own institution, the only two indications for which term babies go on ECMO for respiratory indications in the NICU are either diaphragmatic hernia or lung disease combined with therapeutic hypothermia. Other than that, we rarely put any babies on ECMO here. Why does this happen? There are lots of theories, and currently I'm looking into the mechanisms of hypothermia-induced pulmonary hypertension and response to inhaled nitric oxide in the lab using sheep models. And what we have noticed is that when you are normothermic, with increase in oxygen saturation, when you go from less than 89% to 90 to 94 to 95 to 99 to 100%, there is a gradual increase in pulmonary blood flow, as you would expect. Once you get to extremely high oxygen saturations, you tend to see a drop because of oxidative stress. But when lambs undergo therapeutic hypothermia to 33.5 degrees centigrade, this normal response to oxygen appears to be lost, and pulmonary blood flow tends to be lower compared to normothermic babies. And this is something that we are investigating further as to what could be causing this particular phenomenon in lambs undergoing hypothermia. So this loss of oxygen-induced pulmonary vasodilation during hypothermia requires further investigation. Okay, so if the randomized trials do not show any difference in the incidence of PPHN, why are we seeing increased PPHN in babies undergoing hypothermia in real life? What's the difference between randomized trials and what's happening in real life? To evaluate that, we need to take a step back and look at resuscitation and early oxygenation in these babies. So if you are in a delivery room and you have a baby with the acidotic gas and the baby delivers with asphyxia, there are 4 risk factors that can put babies at risk for developing PPHN. Number 1, high increased severity of asphyxia. The more severe the asphyxia, the higher is the risk of PPHN in these babies. Number 2, requiring extensive neonatal resuscitation, including the need for chest compressions and epinephrine, either endotracheal or intravenous. Then number 3 is predisposing parenchymal lung disease, either meconium aspiration syndrome or pneumonia. These are the 2 most common that we come across. And the 4th factor is need for more than 50% oxygen in the immediate postnatal period. So if you have a baby who meets these criteria and is requiring more than 50% oxygen before the initiation of cooling, that baby is highly likely to develop exacerbated PPHN, and you should be careful while watching these babies. So how much oxygen should we use during resuscitation of term babies? I was one of those people who is senior enough here to have used 100% oxygen for the longest time in these babies until Dr. Ola Saugstad came around and then advised us that we should stay away from 100% O2 and recommended using 21% oxygen in term babies who are born with asphyxia. For the longest time, I had great concerns about using 21% oxygen in these babies because, as all of us know, oxygen is a very powerful pulmonary vasodilator, and why should we not use high concentrations of oxygen? So I was discussing this with Dr. Saugstad once, and we were talking about what happens with room air resuscitation versus 100% oxygen. If you assume the horizontal axis here to be the timeline, and even when you give 21% O2 for resuscitation, there's a significant increase in PaO2 levels compared to the fetal levels in babies. And this gives rise to a small burst of oxygen-free radicals in babies. On the other hand, if you treat these babies with 100% O2, even for a transient period, you tend to see a huge increase in PaO2 levels that can give rise to an increase in formation of free radicals that have been detected in these babies for as long as 4 weeks by Max Venter and his colleagues. In addition, there are long-term consequences of using 100% O2. Studies have shown higher brain inflammation, higher incidence of HIE, myocardial damage, acute renal injury, and in epidemiological studies, increased mortality and a higher incidence of childhood leukemia. So the current recommendation by the neonatal resuscitation program is that in term infants, we initiate resuscitation with 21% oxygen, but then there is always a question of what we should do in PPHN and also in diaphragmatic hernia and cases where there is higher incidence of PPHN. So to answer this question, we evaluated a group of lambs, and these lambs were either control lambs without any prior disease or lambs with severe pulmonary hypertension induced by antenatal ductal ligation. We would tie off the ductus 8 to 9 days before delivery and put the lamb back in the uterus to create severe pulmonary hypertension. As you can see here, babies born with PPHN tend to have much higher, almost a 5 to 6-fold higher pulmonary vascular resistance compared to control lambs. But interestingly, whether you use 21% oxygen shown by the green line or 50% oxygen shown by the orange line or 100% O2 as shown by the red line, the drop in pulmonary vascular resistance over the first 30 minutes of life was very similar between these three groups. So this goes to show that as long as you increase the alveolar PaO2 reasonably well and ventilate the lambs quite well, you will see a good drop in pulmonary vascular resistance, even with 21% or 50% O2 in babies with PPHN. What was even more striking was that once these lambs recovered and initial resuscitation was completed, when they were approximately 90 minutes of age, we went ahead and gave them a dose of inhaled nitric oxide. And what was striking was that those lambs that received 100% O2 for resuscitation for 30 minutes at birth had a decreased vasodilatory response to inhaled nitric oxide compared to those lambs that had received 21% oxygen at birth. And we speculated at that time that this was mediated through superoxide-mediated inactivation of the N-cyclic GMP pathway. To prove that, we went ahead and took tissues from these lambs. And as you can see, lambs that got 100% O2 had really high PaO2 values compared to lambs that got only 21% O2. Their CO2 and pH were very similar. But within 30 minutes, what we noticed was that the pulmonary arteries from those lambs that had received 100% oxygen had significantly higher superoxide anion levels, as shown by the DHE staining of the tissue here, compared to lambs that received only 21% oxygen. All the red stain that you see in pulmonary smooth muscle cells here and airways cells here is superoxide anions within these cells. And interestingly, when we used norepinephrine to constrict these vessels, those vessels that had received 100% O2 showed increased pulmonary vascular contractility, suggesting that these vessels become very twitchy with hyperreactivity in response to catecholamines. And addition of abundant amounts of superoxide dismutase and catalase to remove the superoxide anions from these tissues resulted in that increased contractility being reversed, similar to what had happened in 21% O2 lambs. So this goes to show that resuscitation with 100% oxygen does result in pulmonary vascular hyperreactivity, and this reactivity is at least partially mediated through free radicals, oxygen-free radicals. Okay, so let's get past the initial resuscitation. Let's say we have a really sick baby with severe perinatal asphyxia, and then you go to the delivery room and the baby is born asystolic, and you start doing chest compressions. When we do chest compressions in these babies, the current recommendation is to use 100% oxygen, mainly because the blood flow in babies with asystole or severe bradycardia is so low that if you increase the oxygen content of this blood, there is a better chance of delivering more oxygen to the brain and the lung, brain and the heart, and that's the whole purpose of using 100% O2. But the question is, what do you do once the baby recovers from asystole or bradycardia and has a return of spontaneous circulation, what do you do now? The risk is that when babies recover from asystole or severe bradycardia and have normal spontaneous circulation, the brain is exposed to considerably increased flow and increased oxygen, and this is what we call as hyperemic hyperoxia. So this is due to the fact that soon after recovery from asphyxia, typically we fail to wean oxygen, and so there is hyperoxic ventilation that's continuing. Second, because we used epinephrine, etc., there is some degree of hypertension. And third, because of hypercarbia tends to increase the blood flow to the brain, and all these factors contribute to hyperemic hyperoxia in these lambs. One of my colleagues, Dr. Deepika Sankran, has evaluated this, and she has looked into two forms of weaning. For example, you are on 100% O2 during chest compressions, the baby gets better, and then what do? Do you gradually wean the FiO2 down, or do you abruptly wean the FiO2 down as shown by the green line here? And she has shown through analysis for oxidative stress, etc., that a gradual weaning of FiO2 after recovery of these babies is not the right approach. And these lambs should be abruptly weaned down to around 21 or 30% oxygen and then titrated to maintain oxygen saturations in these babies. So these results have been confirmed by a second group. Shiraz and colleagues at Monash have also done similar studies, and they have shown similar results. So again, gradual weaning of FiO2 after recovery from bradycardia or asystole tends to cause oxidative stress and should be avoided, and abrupt weaning to 21 to 30% oxygen and then titrating FiO2 to maintain saturations is probably the right approach in babies. So one other reason why we should wean the O2 after resuscitation is shown in this study by Vishal Kapadia and his colleagues. What they have shown is that they have looked at the incidence of HIE in babies with perinatal distress, and they have compared that with the first arterial blood gas obtained in the NICU. If the PaO2 in these babies on the first arterial blood gas is more than 115 millimeters of mercury, then their incidence of HIE is much, much higher. On the other hand, if their PaO2 is less than 100 millimeters of mercury, their incidence of HIE is fairly low. So in other words, there is an association between perinatal asphyxia, postnatal hyperoxia, and increased incidence of HIE. Again, I want to remind you that this is not we can't say that there's a causative angle here. It might just be a pure association, but it clearly shows that having perinatal asphyxia and postnatal hyperoxia can be associated with increased incidence of hypoxic ischemic encephalopathy. So let's get back to the original question where we started. Why is it that randomized controlled trials typically have not shown an increase in PPHN with cooling? To evaluate this, we went back and looked at all the trials done by the NICHD network and compared the blood gases in babies that developed PPHN versus those that did not develop PPHN. As you can see from these studies, among babies that developed PPHN in the NRN cohort, the use of high oxygen was very common. These babies were typically on a median of around 80% oxygen and had maintained PaO2 values above 100, close to 150. So this hyperoxic exposure was not uncommon in babies with PPHN in the NRN cohort. And this could be one reason why, at least transiently, we did not see an increase in the incidence of PPHN in these babies. So why is this high alveolar concentration really important in the incidence of PPHN? As many of you know, it is not the PaO2 or the pulse ox or SpO2 that really determines pulmonary vascular resistance. Oxygen influences pulmonary vascular resistance by acting on the precapillary pulmonary arteriole. If you assume this to be the heart, here is the pulmonary artery, here is the alveolus, and here is the pulmonary vein. This precapillary pulmonary arteriole is the site of pulmonary vascular resistance. So the level of oxygen at this particular site is what influences pulmonary vascular resistance. And the number one factor that influences pulmonary vascular resistance here is the alveolar oxygen level, or P uppercase AO2. This predominantly affects 2/3 of the influence on pulmonary vascular resistance. The other third is influenced by pulmonary arterial PvO2, which is the same as mixed venous O2. That influences a third of the pulmonary vascular resistance. A combination of these two are really important. But since we can't continuously measure alveolar O2, we tend to use the surrogate, which is the preductal oxygenation. It's a surrogate for measuring alveolar O2 in these babies. So what are the current recommendations for maintaining oxygen in these infants? There are no clear-cut recommendations, but if you use the general guidelines for management of PPHN, they state that we should maintain preductal SpO2 between 91 and 95% when pulmonary hypertension is suspected or established. And they recommend avoiding lung hyperinflation and atelectasis or lung collapse, and avoid desaturations below 85% or hyperoxia above 97%. And this has a reasonably high level of evidence with a B grade. But the problem with hypothermia is that when you induce hypothermia, the oxygen hemoglobin dissociation curve shifts to the left. And that results in difficulty in interpreting pulse ox versus PaO2, because we know that in babies with PPHN, we need to maintain a PaO2 level between 50 and 80 millimeters of mercury. And typically, this PaO2 level is associated with SATs of around 90 to 97% during normothermia, but during hypothermia, because of the shift in oxygen dissociation curve, you need higher SATs. So we investigated this further with one of my colleagues, Dr. Bushra Afzal. What she did was she took a bunch of blood gases and she measured the PaO2 levels on the blood gas and then compared the pulse ox values at the same time when these gases were drawn. And what she found was that during normothermia, as shown by the purple line over here, maintaining a clinically acceptable PaO2 range between 50 and 80 millimeters of mercury required a SpO2 in the low 90s. On the other hand, when you're undergoing hypothermia, because of the shift in the oxygen hemoglobin dissociation curve, maintaining the same PaO2 required much higher oxygen saturation, somewhere in the 98% range. So since there is a shift in the oxygen hemoglobin dissociation curve, it's possibly prudent that in babies with acute pulmonary hypertension, need to maintain SATs to a slightly higher level in babies that are undergoing therapeutic hypothermia. So again, there is no cookbook approach to oxygen in these babies. For example, if you have a baby sitting here with therapeutic hypothermia with a SAT of 91%, then if this same baby has a SAT of 91% preductal, postductal SAT of 70%, and the baby is only on 30% oxygen and has severe pulmonary hypertension on echo, in this baby, the risk of hypoxic pulmonary vasoconstriction is much higher than lung oxygen toxicity. And so it's okay to increase the FiO2 from 0.3 to 0.45 and improve the saturation in these babies. Because again, the risk of hypoxic pulmonary vasoconstriction outweighs the risk of oxygen toxicity in this baby. On the other hand, if the same baby with 91% SATs is already on 90% oxygen, but the lactate is normal and there is no acidosis, it's probably okay to closely monitor pH, lactate, and urine output and not change the settings and leave the baby on 90% oxygen without going up further. Because of the high FiO2 here, the risk of oxygen toxicity outweighs the risk of hypoxic pulmonary vasoconstriction. So a same SAT in two babies may need to be managed differently based on the FiO2 and various other factors. So there is no cookbook approach to saturation ranges in babies with PPHN and HIE. You need to evaluate several other factors before determining the optimal approach to oxygenation in these babies. Okay. So the second way to improve oxygenation is obviously to recruit the lung. And one effective way of doing that is with the use of surfactant. And this trial from Chile, where Dr. Gonzalez and his colleagues evaluated a bunch of babies with PPHN, a significant number of them had meconium aspiration syndrome, where they gave nitric oxide to one group and surfactant followed by nitric oxide to the other group, and showed that the group that got surfactant and nitric oxide had a much more significant decrease in oxygenation index compared to the other group. And this trial was highly significant from a statistical perspective. So why does this happen? If you have a baby with a collapsed alveolus and an over-distended alveolus, and both of these are diseased either with meconium or due to secondary injury from hypoxic encephalopathy, you tend to develop PPHN because of hypoxic pulmonary vasoconstriction next to the collapsed alveolus and compression of the pulmonary vessels with the over-distended alveolus, and both of which contribute to increased pulmonary vascular resistance. So in this situation, If you give nitric oxide, the nitric oxide cannot enter the collapsed alveolus, so it doesn't help over here. The nitric oxide does enter the distended alveolus, but this alveolus is so distended that it's already compressing the adjacent pulmonary vessels. So nitric oxide will not be that effective. So this strategy will not really yield with much improvement, as you can see with this curve with the gray squares. On the other hand, if you open up the lung with surfactant and distend the lung uniformly and recruit the lung well, and then use inhaled nitric oxide, then you will see nice and uniform pulmonary vasodilation, and that results in decrease in pulmonary vascular resistance. So use of surfactant is really beneficial in babies with asphyxia and pulmonary hypertension if they have any evidence of parenchymal lung disease. So the second concept that comes up very often while maintaining these babies, I don't know if any of you do this, is as to whether these babies should be parked at a floor FiO2. In other words, if you have a baby with severe PPHN undergoing cooling, you do not wean the oxygen below 30%. That's the lowest you will go to, and that's what we call as floor FiO2 or parking FiO2. So the argument here is that as alveolar oxygen, or P uppercase AO2, is an important determinant of pulmonary vascular resistance, some NICUs do not wean below 30 to 40% oxygen, irrespective of PaO2 and SpO2. And the idea here is they want to provide a buffer during hypoxic spells and reduce lability. But the problem here is that with maintaining oxygen at 30 or 40%, you can maintain oxygen above the physiological range and cause toxicity. So we wanted to evaluate this practice, and what I did was I put a question on Twitter just to get people's response to see how many people are even considering it. And to my surprise, only 56% of the 192 respondents would wean the oxygen down to 21% as long as the SATs are above 90%. Close to a quarter would use a floor FiO2 of 0.3. They would not wean below 0.3. 14% would not wean below 0.4, and 5% would not wean below 0.5 FiO2. So this response was quite striking, and I was quite surprised to see this. So we went ahead and did a study, which we'll be partly presenting at PAS, where we looked at lambs, and maintained them either with 100% O2 all along the whole 6-hour period, or maintain FiO2 where we did not wean below 30%, that's shown by the orange line here, or wean the FiO2 all the way down to 21%, as long as the PaO2 was above 45 millimeters of mercury and SpO2 was above 90%. And interestingly, although the PaO2 levels were vastly different between the three groups, especially in the 100% O2 group, interestingly, we did not see any difference in PVR, suggesting that going down to a floor FiO2 all the way down to 21% does not really cause much damage in these babies. And so we did not find any benefit in lamb models of maintaining a high floor FiO2. And if you have to maintain a floor FiO2, don't go above 0.3, because anything above 0.3, you might be subjecting the baby to higher oxygen toxicity. So to conclude this section on oxygenation during HIE and PPHN, initiate resuscitation in these babies with 21% oxygen. And if it's a moderately preterm baby, you can consider 21 to 30% oxygen. Do not reduce the need for 100% O2 in the delivery room is possible, because this can lead to oxidative stress and decreased response to inhaled nitric oxide later on. Then titrate the FiO2 based on the oxygen saturations dictated by the resuscitation panel, and try to get to a goal FiO2 of whatever is required to maintain SpO2 of more than 80% by 5 minutes. I know this rule has been promoted by Julie Oy in her studies in preterm babies, but even in term babies, this seems to play an important role, especially in babies with diaphragmatic hernia, etc. And then if the baby requires chest compressions, you increase the oxygen to 100%. And once the baby recovers spontaneous circulation, try to wean the baby down to 21% or 30%, and then titrate up. Instead of gradually weaning the baby down, abruptly wean the FiO2 down. Avoid PaO2 values above 100 millimeters of mercury to reduce the association with HIE. And once the baby is stable, check blood gases, maintain blood gases with a PaO2 between 50 and 80 millimeters of mercury, corrected for body temperature, or maintain SpO2 slightly higher between 93 to 98%, instead of the usual 91 to 95% in these babies, because the oxygen hemoglobin dissociation curve is shifted to the left with hypothermia. Okay, that concludes the oxygen section, and we will jump into carbon dioxide. So let me start off with a theoretical case. A 39-week term infant with perinatal acidosis following an abruption. This baby has severe asphyxia, has a poor gag reflex, has pooling of secretions in the mouth. You try to take the endotracheal tube out, but you can't because there is so much of secretions. Baby is a bit depressed and is currently having seizures and is requiring anti-seizure medications. The baby is on a conventional ventilator and you get a blood gas. It shows severe metabolic acidosis with hypocapnia. And the baby is quite tachypnic and has a PO2 of 132, PCO2 of around 30 millimeters of mercury. And the baby keeps on triggering the ventilator. Despite a decrease in trigger sensitivity, you have reduced the pressure support to minimum. The rate is fairly low and the tidal volume is fairly low, but the baby is still breathing pretty fast. And typically this rapid breathing and hypocapnia is secondary to presence of secondary energy failure, lower metabolism during therapeutic hypothermia, and metabolic acidosis with compensatory hyperventilation. So what do you do here? This is it. There is no right answer here, and I have had people try different things. Some individuals give a really small dose of sodium bicarbonate to correct the metabolic acidosis and hoping that correction of acidosis and improving the pH results in reduced hyperventilation. Some people extubate to CPAP or high flow nasal cannula or put the baby on endotracheal tube CPAP without any pressure support to increase resistance and bring the CO2 up. Some people sedate these babies, some people paralyze these babies, and some people give a fluid bolus hoping to correct the metabolic acidosis using a fluid bolus. I'm not sure what you do. I personally tend to wean the rate and get the rate to a minimum. And occasionally I have used a very small dose of sodium bicarbonate given very slowly over like a 30-minute period to see if I can combat acidosis in these babies. But nobody has studied the right approach to these infants who are hypocapnic with therapeutic hypothermia and have metabolic acidosis. And in my unit, there's a lot of these babies land up getting fluid boluses, and I just want to talk for a second about fluid boluses. We are all traditionally used to giving more and more normal saline in these babies. The assumption here is that there is some fluid loss, or maybe there is some hypovolemia, and let's give some normal saline. And the issue by using sodium chloride is that sodium chloride is a very hyperchloric solution. It's acidotic with a pH of 5.0, and it can cause hyperchloremic acidosis and contribute to metabolic acidosis in these babies. In contrast, Ringer's lactate is a better solution with a lower sodium chloride concentration of 109 millimoles per liter compared to 154 in normal saline. And the pH is much better and much closer to normal, with around 6.5. The issue here is that many of us use serum lactate as a measure of hypoxemia and ischemia. And since Ringer's lactate has 28 milliequivalents of sodium lactate per liter, giving a lot of Ringer's lactate, close to 30 ml per kg, can increase serum lactate by 1 millimole and can cause some confusion while managing these infants. But typically, I personally tend to prefer to use lactated Ringers if the baby requires volume and there is evidence of reduced preload in these babies. But it's an individual choice. In some places, in some situations where you have blood loss, you need to use whole blood or packed RBCs or fresh frozen plasma. But I just want to warn that using too much of normal saline can give rise to hyperchloremic acidosis and can cause more problems in some babies. Okay, where should we maintain CO2 in these babies? Here is a graph showing pulmonary vascular resistance in lambs with asphyxia and meconium aspiration. And as you can see here, if the PaO2 is high, above 100 millimeters of mercury, the PVR is low. When the pH is low, a combination of acidosis and hypoxemia. When you have acidosis with a pH less than 725 and a PaO2 less than 50, you tend to see exacerbation of pulmonary hypertension. So this is where you see acidosis and hypoxic pulmonary vasoconstriction. On the other hand, if you maintain alkalosis, then even hypoxia does not cause much hypoxic pulmonary vasoconstriction. But the problem with alkalosis is that whenever you have alkalosis, you tend to decrease your cerebral blood flow or carotid blood flow. And that's the reason why alkalosis should be avoided in babies with undergoing therapeutic hypothermia with HIE and PPHN. So as this was confirmed by Athena Papas and her colleagues in babies from the NRN trial, what they did was they classified babies into 5 groups based on the amount of time they were hypocapnic. So this was cumulative exposure to a PaCO2 of less than 35 millimeters of mercury. If they did not have any time at all with a PaCO2 less than 35 millimeters of mercury, those babies had an incidence of around 35% of death or neurodisability at 2 years of age. On the other hand, if they spent a lot of time in hypocapnia, then they had a much higher incidence of death or neurodisability at 2 years of age. So in other words, more time you spend in hypocapnia tends to cause more death and neurodisability. The less time you spend in hypocapnia tends to cause less death or neurodisability. And for this reason, it's really, really important to avoid low PaCO2, especially less than 35 millimeters of mercury. And this is corrected for temperature when you're managing babies with therapeutic hypothermia. So temperature is a really interesting phenomenon, and I'm not really sure what you guys do in your center. In the US, approximately 70% of the units tend to correct the blood gas for the body temperature. The other 30% don't correct it. So when you correct and report the results at 33.5 degrees centigrade, this method is called as pH stat method. Whereas if you report the blood gas at 37 degrees centigrade, then that approach is called as alpha stat method. Just to clarify, whenever you draw a blood gas and put it into any machine, this machine warms the blood to 37 degrees centigrade and then calculates the PaO2, PaCO2, and pH. And then mathematically using an algorithm corrects for whatever body temperature you put in. So again, there are 2 methods of management: pH stat, where you correct and report the blood gases at the baby's body temperature, and alpha stat, where you report the blood gas at 37 degrees centigrade. So both of these have been used in many centers. I personally prefer to use pH stat, and I'll give you the reasons in the next couple of slides. So all the randomized trials to date of therapeutic hypothermia have used pH stat for HIE. Babies undergoing deeper cooling for cardiac surgery, those babies have studied both alpha stat and pH stat. But as far as HIE is concerned, every single study that I'm aware of has used the pH stat method. So to get into this, it's a little complicated, and I know this is not something you're expecting soon after lunch, but gas laws really play a very important role. Boyle's law, as you remember, is P1V1 is equal to P2V2. In other words, the pressure times volume is a constant number at a constant temperature. Charles' law is V1 by T1 is equal to V2 by T2. But the one that we need for today is Guy-Lussac's law, which says that at constant volume, pressure is directly proportional to absolute temperature. In other words, P1 by T1 is equal to P2 by T2. This sounds like Greek, but all I want to say is that if the temperature decreases, the pressure also decreases. Okay, I think I confused you enough here. So let's take a step back. I'm sure many of you like drinking soda or whatever you call it that comes out in a can, and you open this can, there is always gas in it under pressure. So we all love drinking soda that's cold, mainly because the cooler the liquid inside the soda can, the more carbon dioxide dissolves in it. In other words, if you have blood at a higher temperature, many of these gas bubbles tend to be like this. So here, the blue circles are dissolved gas, the white circles are undissolved gas. So at higher temperature, less gas is dissolved, and so more gas is not dissolved, and hence the pressure is much higher. But once you cool, like the way you cool a soda can, then more carbon dioxide dissolves into the water. So there are more blue circles here. These are dissolved carbon dioxide molecules, and very few molecules are not dissolved. And for that reason, the pressure of carbon dioxide decreases as the temperature goes down. So let me give you a theoretical example here. You come to the unit and you are using the alpha stat method. In other words, you report blood gases at 37 degrees centigrade. Here you have a baby who is being cooled, whose real PCO2 is 45, totally normal value. But since you're not using a pH stat method and you're using an alpha stat method, you record the baby's PCO2 to be 53, and you're worried that it's a bit too high, and so you hyperventilate, you start increasing the ventilation on this baby, and then you bring the CO2 down to a normal value of 40 millimeters of mercury. This value of 40 millimeters of mercury at 37 degrees centigrade is the same as having a low value of around 34 millimeters of mercury at 33.5 degrees centigrade. And as I showed you in the previous graph, having PaCO2 values below 35 is not good for the brain. And for that reason, I personally prefer to use the pH stat method. So I like correcting for temperature, and I tolerate PCO2s in the 40s and mid 40s and low 50s in babies with hypoxic encephalopathy and PPHN. One of the reasons why pH stat method is preferred, at least theoretically, is that with pH stat method, the PCO2 values tend to be slightly higher. And as we know, having slightly higher PCO2 values tends to cause cerebral vasodilation. And when you have cerebral vasodilation, you get much more uniform cooling with whole body hypothermia than what happens without cerebral vasodilation. So maintaining slightly higher PaCO2 values with pH stats tends to promote more uniform cooling of the brain and hopefully with better outcomes in these infants. So to conclude this section, if you have a baby with PPHN who is normothermic, then it's fine to maintain SATs between 90 to 97% and PaCO2 between 45 and 60 millimeters of mercury. On the other hand, if a baby is undergoing whole body hypothermia, you need slightly higher SATs because of the shift in oxygen hemoglobin dissociation curve. You tend to maintain SATs between 93 and 98%, and the PaCO2 you tend to maintain between 40 and 55 millimeters of mercury when you correct for body temperature. If you're not correcting for body temperature, you maintain a PaCO2 even a bit higher, 45 to 60 millimeters of mercury. So this is the general guideline for what you do during normothermia and hypothermia. Okay, in the interest of time, I will quickly go through a couple other slides. So it's really important to maintain decent fetal hemoglobin values in these babies, because as you can see from this curve, from this oxygen dissociation curve, if you have a baby who is hypoxemic, having more fetal hemoglobin in these babies will result in better delivery of oxygen to the tissues than having adult hemoglobin. So having higher fetal hemoglobin really helps. And there's a recent study that came out, I believe from Sweden, which showed that if you have more fetal hemoglobin, you tend to need less FiO2. In other words, let's say you have a baby who is SATing 93%. To get this SAT of 93%, if you have hemoglobin A, you need much higher FiO2 and a much higher PaO2 compared to when you have more hemoglobin F, where you can get away with lower FiO2, lower alveolar oxygen, and lower PaO2 values. So having more fetal hemoglobin tends to reduce the risk of oxygen toxicity. And as you know, there is only one source of fetal hemoglobin in the world, and that's the placenta. And so I'm a strong proponent of doing cord milking in babies who are not vigorous based on Anup Katheria's trial. And so many of our babies who are undergoing asphyxia, we request the obstetrician to quickly milk the cord 4 times and give the baby to us. Okay, I will briefly talk about the heart in a second. Systemic hypotension is very common in babies with PPHN, and every single drug that we use has one effect or the other. There's a lot of work being done on the use of sildenafil in these babies, and Pia Wintermark from McGill in Montreal is evaluating the role of sildenafil as a potential neuroprotective agent. The dopamine, on the other hand, has non-specific pulmonary vasoconstriction effects and can be harmful in babies with severe PPHN. Vasopressin is quite good, but the risk of hyponatremia and oliguria is much common, especially in babies that have acute tubular necrosis, which is common in babies with HIE. Norepinephrine tends to cause cardiac dysfunction and tends to increase the afterload without helping the heart as much with inotropic effect. And for that reason, it will not be very effective in babies that have severe cardiac dysfunction. And finally, milrinone has poor clearance due to renal dysfunction, and that could be a problem in these babies. So one concern with using dopamine is that dopamine is not selective to systemic circulation. For example, here are some control lamps where we used increasing doses of dopamine. And with dopamine, there was an increase in systemic blood pressure without much increase in pulmonary arterial pressure. But on the other hand, if you had a lamp with PPHN, in these PPHN lamps, the pulmonary arterial pressure was already higher at baseline. And with the use of dopamine, the pulmonary arterial pressure went up quite a bit. And so this clearly shows that dopamine is not selective in babies with PPHN. And this has led to this whole discussion about banning dopamine in PPHN, or what is called as death to dopamine, which was a popular talk by Audrey Hibbert from McGill last year at PAS. So the second drug that we commonly use is milrinone. One of the risk factors with babies with asphyxia, with or without hypothermia, is that they're more commonly prone for developing LV dysfunction. And when you have left ventricular dysfunction, you tend to have elevated LA pressures. So although you have a right to left shunt across the PDA in these babies with high LA pressures, you may see a left to right shunt across the PFO. And in these babies, there is a high risk of having pulmonary venous hypertension and pulmonary edema. And in these patients, if you use more of inhaled nitric oxide in the presence of LV dysfunction, you can cause worsening of pulmonary edema. This is what I compare to having a potty or a toilet with an occlusion, which is the same as LV dysfunction. If you keep on flushing this toilet by using nitric oxide, you tend to cause a mess and cause more pulmonary edema. The right treatment here is to use a plunger or whatever you call this gadget, and you get rid of the obstruction. And once you get rid of the obstruction, then baby you can start flushing. So use of milrinone is probably really important in these cases to improve left ventricular dysfunction. But the problem with using milrinone is that many of these babies tend to have renal dysfunction. And Patrick McNamara and his group have shown that in the presence of renal dysfunction, when there is slightly high creatinine levels, use of milrinone can cause a significant drop in both systolic and diastolic blood pressures. And especially babies that have high creatinine, you should be really cautious in using milrinone. So check creatinine levels. And if these are high, try to avoid milrinone. And if you absolutely need it, don't use a load and use a really low dose of milrinone, and carefully watch blood pressure in these babies. The last drug I want to talk about is hydrocortisone. As many of you know, in babies with hypoxic ischemic encephalopathy, there is usually a deficiency of cortisol, and especially soon after birth, they develop a relative adrenal insufficiency, which can lead to catecholamine resistance hypotension. So there are some studies that have shown that in babies at the verge of ECMO, using a bit of hydrocortisone might help with improvement in blood pressure, decrease in inotropic score, decrease in oxygenation index, and improvement in PaO2 levels. And more recently, there has been a study where they used a small dose of hydrocortisone, 0.5 milligrams per kg for every 6 hours versus placebo, and showed that the use of hydrocortisone resulted in a significant decrease in the need for inotropes and better blood pressure in these babies. So many of these babies land up requiring a combination of hydrocortisone and sometimes epinephrine to help their blood pressure. The last controversial topic in babies with asphyxia is shown by this case. Let's say a baby is being transferred to you. This is a hypoxemic infant on whole body cooling is being transported to you. This baby is a 39-week large gestation age infant of a diabetic mother, has severe hypoxic ischemic encephalopathy with meconium aspiration syndrome. He's on a cooling device on transport. He's requiring 100% oxygen already. It is on a high-frequency oscillator and has poor saturations despite being on inhaled nitric oxide and has stable blood pressure. When you have a baby like this who is undergoing hypothermia and has severe PPHN and is hypoxic despite 100% O2 and nitric oxide, the correct management here is not clear. Some centers start rewarming these babies and monitor oxygenation because they really want to avoid ECMO and they really don't want to subject this baby to more cooling, and they start rewarming. The second approach is to continue hypothermia and add a second vasodilator such as IV sildenafil and see what happens. Sometimes this works, sometimes this causes severe systemic hypotension, so you should be careful about that. Some centers, including ours, we do not rewarm these babies, but instead put the babies on ECMO and reduce the circuit temperature to 33.5 degrees centigrade. There's a slightly higher risk of hemorrhagic complications with this, so we tend to monitor the coagulant profile very carefully in these babies. And some centers put the baby on a cold ECMO circuit and gradually warm the circuit back up to 37 degrees centigrade. There is no right or wrong approach here. What I personally do is that if the baby has moderate encephalopathy and will benefit from cooling, I put the baby on ECMO and cool the circuit on ECMO. On the other hand, if the baby has only mild HIE or very severe HIE where there may not be any benefit, I rewarm these babies and monitor oxygenation. So either I use this box or this box based on the severity of HIE and the baby's status. Okay. With that, I want to conclude by saying that lung recruitment and surfactant are really important in babies with HIE, meconium aspiration syndrome, and PPHN. targeting slightly higher SATs are important because of the shift in oxygen hemoglobin dissociation curve, but avoid PaO2 more than 100 millimeters of mercury to avoid increased association with HIE. So you have a really narrow therapeutic window for oxygen. With PaCO2, avoid hypocapnia because that's associated with bad neurological outcomes. And my personal choice, if there is LV dysfunction and hypoperfusion, is a combination of epinephrine with some hydrocortisone. And close hemodynamic monitoring is really important in these babies. And again, when you manage these babies, have a big picture because many of us focus on one small aspect of these infants. For example, if this is, many of you are familiar with the 4 blind men and the elephant story, where 4 blind men come in contact with an elephant and one of them thinks they're touching a snake. Some people are thinking they're touching a rope. One person thinks he's touching a wall, but nobody has a big picture. Similar to that, when we manage these babies with hypoxemic respiratory failure and HIE, one of us might be focusing on lung disease and wanting to give oxygen and surfactant. The other group might be thinking of hypertension and wanting to use vasopressin. The third person might be wanting to use inhaled nitric oxide because of high PVR, and the last person wanting to use milrinone for ventricular dysfunction. So in these babies, it's good to take a step back and get a global picture of the baby and choose the right drug based on the whole baby and not one organ system in particular. And also remember that these babies are very dynamic. For 1 second, they can look like this, and the second, they may totally turn around and look very differently. So be constantly examining, reevaluating these babies and manage them. All right, thank you for your attention, and we have a few minutes for questions.
Oh, thank you, Satyan. That was a wonderful overview, but also it's a story, isn't it? It starts with epidemiological data, looking for associations and finding that there is an association with therapeutic hypothermia and PPHN. Then you try to explain these associations with animal studies and some clinical data, looking for mechanistic sort of changes, which apparently is still difficult, but particularly the role of oxygen and what happens to then the pulmonary vasculature or pulmonary vascular resistance. You have beautiful data there. And then you just told us, again, sort of first year physiology, back to the role of temperature on SpO2 and O2, and also on CO2 and in its association pH. And then you took us to some newest thoughts about cardiovascular dysfunction in this particular situation, which can be quite challenging and quite changing from moment to moment. We indeed have time for some questions, and there's one question there which was on my mind as well. When you explained the association between hypocapnia, is it the CO2 or is it the pH?
That's a really tough question, but based on current physiology data from animal studies, it's at least assumed that the pulmonary circulation mainly depends on pH, whereas the cerebral circulation is predominantly affected by PCO2. So even if you have an acidotic gas, like the example I showed you, and you have hypocapnia with a pH that's less than 7.25, even those babies tend to have low cerebral circulation, and we see it again and again in our lamb models. So we have a lamb model of meconium aspiration syndrome with asphyxia induced by umbilical cord occlusion. And although these lambs are really acidotic with pHs often less than 7, the moment they become hypocapnic, you start seeing a drop in carotid blood flow. So the carotid blood flow is very sensitive to PCO2 values more than anything else. We should also remember that as following asphyxia, the cerebral circulation loses its autoregulation, and so it becomes pressure passive and PCO2 passive. So it responds, the effect of PCO2 is much more profound in some of these babies, and so we should be very careful to avoid hypocapnia in this infant. So it's not an effect of pH, it's an effect of hypocapnia. But the person asking the question is true, the fact is true that babies with really acidotic cord gases tend to have more severe asphyxia, tend to have more hypocapnia, and may have poor outcomes. So there might be an association between the severity of asphyxia, hypocapnia, and poor outcomes. So that's definitely a possibility. So I think he or she is totally right.
respiratory drive can be affected in HIE is one of the concepts I always thought was taught. That's why they're breathing indeed too fast and it's good for themselves. You mentioned the relationship between the autoregulation in the brain and how that is pressure related. Is there a recommendation for pressure, let's say blood pressure, in these scenarios?
Not that I have seen one. But it's the issue with these babies is that let's assume there's a narrow range of autoregulation in a term infant. That range of autoregulation, let's say it's between 30 and 60 millimeters of mercury, that range becomes narrower and narrower the more severe asphyxia occurs. So it's most babies with severe or moderate to severe HIE tend to become very pressure passive without any autoregulation. So it's fairly important to maintain a good blood pressure, but maybe you're aware, Kurt, we really need a study to see what is the optimal blood pressure that we need to maintain good cerebral perfusion. The other challenge during cooling is that all the blood flows go down during cooling because the heart rate goes down. So what is normal, what is abnormal, what is too low is very difficult to predict in these babies because both in animal models and in clinical trials, the moment you start cooling, the pulmonary blood flow goes down, the cerebral blood flow goes down. That's how body reacts to low metabolism. So it's tough to figure out what is appropriate and what's normal blood flow versus what's low blood flow.
We got time. We was going to do one more question, if that's all right, which is about the use, for instance, of dobutamine in cardiac dysfunction. What will be the good time to start? As early or wait for it? When do you want to start?
Yeah, so dobutamine is a really interesting drug. So the question is, if you have LV dysfunction or cardiac dysfunction, you need an agent to improve cardiac function. You have three choices for the most part: AP, dobutamine, and milrinone. You can use dopamine and other things too, but these are your main choices. So if you have a baby with a combination of systemic hypotension and pulmonary hypertension, I personally avoid using dopamine in those cases because I'm really nervous about increasing pulmonary vascular resistance. So my choice typically boils down to milrinone, dobutamine, or AP. So among these three, if there is no kidney dysfunction, I tend to go to milrinone first, mainly because milrinone does not, at least theoretically, does not increase myocardial oxygen consumption. So that's one advantage with milrinone. So I tend to go to milrinone first. On the other hand, if there is significant renal dysfunction and the risk of systemic hypotension is higher with milrinone, then I jump to dobutamine if the blood pressures are reasonable, or AP if the blood pressures are slightly on the lower side. So that's how I approach management of hypoperfusion in these babies. I don't use that much of dobutamine. I tend to use either AP or milrinone more, but there's nothing wrong in using dobutamine in select cases.
Well, Satyan, thanks so much again for presenting. I bet we're all going to look at our gases and what temperature we're actually measuring it, because I don't think, when I listened to your talk last time, that's the first thing I did, and it was quite variable within my unit, what people would do. So try to uniform that within your unit. This was great material to think about, and thank you so much again for presenting. I think we're back next week with another lecture, and hope to see you all back then next week. Thank you very much. Thanks, Satyan.
Everyone, talk to you today. Bye.